Everyone, and welcome to the Interfacility Transfer Deep Dive. Just a couple of housekeeping issues before we get started. All the attendees will be in muted status for the entire call. If you have any questions for us, please use the chat feature or the questions section. On your control panel, a member of our team will try our best to answer your questions at the end of the session if time allows. Otherwise, any frequently asked questions will be posted on our file sharing site. The deep dive for today will be recorded and slides will be available. You can also download a copy of today's intervention bundle by visiting the site listed on your screen, or in the handout section you will find a copy of the intervention bundle as well as a Sentinel toolkit to use. So again, welcome everyone to the Pediatric Interfacility Transfer Bundle Deep Dive session. Today you will hear from Kate Remick, myself, Crystal Bartley, and Diana Fingia. A couple of acknowledgments. The MSC Innovation and Improvement Center is supported in part by the Health Resources and Services Administration. The information or content that will be disclosed during today's session should not be construed as the official position or policy of any of the entities that are listed here. For today's session, we are offering CNE and CME Credit. You'll see the link that's listed on the screen as well as in the chat box. We encourage all of our physicians and nurse providers to visit the survey link, and the name of today's session is Transfer Deep Dive, and we will also bring this back up at the end of the session as a reminder. So for today's Interfacility Transfer Bundle Deep Dive, here are our talking points. We will review the IHI Collaborative Model, sort of discuss some of the common concepts for QI collaboratives, review the support available for our affiliate sites. Kate Remick will spend some time discussing the PRQC's culture. We'll spend some time reviewing the framework for this bundle. Diana will give you a deep background into interfacility transfers. We'll discuss the aim statement, change strategies, quality measures, and variables. And then at the end, we'll save some time for next steps and housekeeping. So here you'll see the IHI Collaborative Model. The PRQC follows this somewhat stringently. We've selected the topic, 4 topics for our collaborative, and today we will be focusing on interfacility transfers. We recruited faculty members or subject matter experts to assist us in the development of the intervention strategies that you'll hear today. We will review those change strategies and the framework for this bundle for the next 30 minutes or so. And so we've encouraged all of our participating sites to join the call today to learn more information about how they will be implementing this potential bundle at their hospitals. Over the next year and a half, we will be hosting learning sessions, and during this time, we will share best practices. Sites will have an opportunity to review aggregate data for the collaborative specific to each intervention bundle. And then between those learning sessions, each site is really working hard to roll out these iterative improvement cycles. And so some of these change strategies today should be implemented at your hospital for the next year and a half. And so what we'll do is provide you with some common concepts that you'll hear over the next year and a half. You will hear us discuss aim statements, the model for improvement or PDSA cycles. There will be an extensive discussion about our quality measures. How are we performing? How are we keeping benchmarking data? And some of the tools that we'll use include the key driver diagram. You'll see workflows, process maps. There will be some discussion about SWOT analyses, fishbone diagrams, or cause and effect diagrams. So over the next year and a half, these will be some of the common concepts that you'll hear us discuss. Some of the support that we're providing for our 146 affiliate sites includes the first level, which are trainers that have committed to providing mentorship to a series of affiliate hospitals on their team. These trainers have expertise in pediatric emergency medicine, quality improvement, and emergency medical services for children. Level 2 is the formal QI education that will be available through the Institute for Healthcare Improvement Open School, and we'll also be reinforcing these concepts throughout the collaborative. Later during today's session, you will hear Kate and myself sort of reinforce how we'll actually implement these IHI modules. We know that some sites were expecting to receive the login information on July 1st, but what we've actually decided to do is wait for sites to establish their data use agreements to ensure that they are participating in the collaborative, that they are submitting data, and then we'll be releasing contact information or registration information for those modules. The next level of support that we'll be providing will be the sharing of best practices. We will host intervention-specific webinars and learning sessions. So if you are participating in the interfacility transfer bundle, we will have sessions specifically for your team to really share those best practices, understand what barriers are there. Our subject matter experts will also be providing some insight into strategies that you may want to implement. And lastly, we will make a concerted effort to distribute any new content or resources that are available, and that information will be posted on our file sharing site. And so now I'll pass the mic to Kate, and she's going to discuss the PRQC culture.
Great, thank you, Crystal, and good morning or good afternoon, everyone, depending on where you are. Thanks so much for joining us today. We talk about the PRQC culture a lot and have mentioned them during the other deep dives, but we want to make sure that everybody has a chance to understand why we're all here and the culture that we're hoping to foster throughout this collaborative. We're all here, of course, to ensure that children have access to high quality emergency care, and we're all here to do our best to make sure that happens at our individual sites. And so as part of this process, certainly we're all here to learn, but we're also all here to learn from each other. So it's really this all teach, all learn philosophy. We also are very much supporting transparency across that, which is that we can't really understand the barriers or challenges that each of us is facing unless we're transparent about them. And it's only through that transparency that we're really able to help support one another through this process. We are all beginning at different stages. We all have different levels of support at our institutions, and we all have a different background or experience with quality improvement and or pediatric readiness. So any improvement for any of us is success. It doesn't mean that we all achieve our ultimate goals for every single bundle. It means that we make progress towards our goals, and each of those small steps should be celebrated. We will be sharing our progress and our challenges with the trainers, and hopefully we'll all move forward together in a team spirit. So Crystal, you can go on to the next slide. Many of you are very aware of the structure of this collaborative. We, of course, have these learning sessions. We also have office hours, and we have the regular conference calls that will be related to each of these bundles. But one of the core pieces of the Pediatric Readiness Quality Collaborative is that of having teams or being part of a regional team. And so each of you are part of a team that includes at least one trainer from a training site and all of those affiliate sites. And those trainers are charged with helping to support all of you and create a cohesive group. These are planned exclusively by the training site to develop these meetings with each of the pediatric champions from the affiliate sites. These may not occur in person. They may end up being virtual. They may be via teleconference, and it really depends on the resources and the distance between all of you at the various sites. But look out for your trainers to be reaching out to you to schedule these meetings. Some may have already started, but they will be working closely with you all to make sure these happen on a regular basis. And some of the topics of discussion you'll see listed here. So really talking about what bundle each site might be working on, how they're going to implement specific changes, discussions around hospital engagement, how to integrate quality improvement science into the work that's being done, and the discussion of progress. And all of this is really critical to be successful, and this is where that transparency really comes in. We will not be sharing anyone's specific performance or data from any site with any other site, meaning we will not be sharing affiliate-specific performance with the training site. That's entirely up to you to do, but we encourage you to be transparent during these meetings so that you all can help each other. That doesn't mean that you necessarily have to share your exact performance on measures, but we certainly encourage you to share the challenges and barriers that you may be facing during the course of the collaborative. If you go to the next slide, Crystal. So at this point, we're going to go ahead and get into the deep dive for the interfacility transfers of pediatric patients. As you know, at this point, this is the general framework for each of our bundles. They begin with a brief background or introduction to why we're focused on this particular intervention, why it's important, and how it can help to improve care for children. We have some key terms listed. Of course, a global aim statement. This is not a site-specific aim statement. This is what we hope that all of you who participate in this bundle will achieve, but each site is charged with developing their own personal aim statement that they hope to achieve relative to each of these bundles throughout the course of the collaborative. We'll also talk about the quality measures that will be helping to support you. So true to quality improvement, you can't measure improvement without some kind of analytics, and that's why we have to have measures where we're actually doing some kind of data collection that you can then see how the changes that you're implementing are resulting in improvement. We'll talk about what the data pieces are, and then lastly, we'll go through some of the intervention strategies and the resources that will be available to you. If you go to the next slide. So as you all know, this is the first of the Pediatric Readiness Quality Collaboratives. You all are indeed the first cohort, so to speak. And so while this intervention bundle was developed in hopes that it would be very useful for all of you to be able to demonstrate your own improvement, because it hasn't been utilized before, we ask that you not share this or use this for other purposes without written consent. Know that there may be certain elements of the bundle that conflict with your existing improvement efforts at your institution, and we are not suggesting that you, implement any efforts that would misalign with those local efforts or processes that might be in place. We absolutely encourage you to seek support from your ED and hospital leadership regarding adoptions of any of the proposed change strategies, and this will help also to make sure that whatever strategies you do implement are effective. And then lastly, that family-centered care is really a cornerstone of this particular intervention bundle, as we're talking about children who are being transferred typically away from a facility within their community or away from their medical home to a more distant site. And for that reason, family-centered care is key to this bundle. And lastly, because we are talking about interfacility transfers, it's strongly encouraged that there be collaboration with any major receiving centers that might be receiving these patients who are transferred so that you can better understand the needs and the ultimate outcome for these children. If we go to the next slide. We were very fortunate to welcome 3 subject matter experts to help support this. Lisa Nichols, who is the trauma program manager at Dell Children's Medical Center in Austin, Texas. She's also been a significant proponent of pediatric trauma work as a board member with the Pediatric Trauma Society and has been very engaged in the development of this bundle and of quality measures related to pediatric transfers. Sally Snow is a longstanding supporter of pediatric readiness. She was one of the original co-authors of the 2009 guidelines. She is a co-author of the upcoming 2000, or at least anticipated 2018 pediatric readiness guidelines. She was also intimately involved in the development of the Interfacility Transfer Toolkit, which you'll see as a resource throughout this bundle. And then lastly, Dr. Tony Woodward, who is the medical director of the emergency services at Seattle Children's Hospital in Seattle. He is also the past chair of the American Academy of Pediatrics Transport Section and has a wealth of knowledge and expertise related to interfacility transfers, not just for trauma patients, but certainly related to medical patients as well. And we're really grateful to them for providing some support and input on this bundle. So at this point, I'm going to turn this over to Diana Finja, who's going to speak a little bit about the background behind interfacility transfers.
Good morning or good afternoon again, and thank you for joining us once again as we go over the interfacility transfer bundle itself. My goal over the next few minutes is to review some facts and some information that will be validating the need for every hospital to have interfacility transfer processes in place. We know that approximately 31 million children and adolescents under the age of 18 visit an ED each year, and many of these children are children under the age of 3. Most of these children are treated, they do well, and they are discharged to home. Pediatric emergency visits account for approximately 27% of all emergency department visits that occur. Many of these visits occur in smaller hospitals where less than 14 children are seen per day. We know that 69% of pediatric emergencies are seen at local community hospitals. These are hospitals where children live, in areas that their homes exist, where their medical homes exist, and sometimes the providers in these emergency departments, if they're lucky, are their friends and our family members. Approximately half of these visits to the emergency departments are injury related. Some of these patients will be treated again and will be discharged to home, but some of them will fall underneath the trauma system regulatory guidelines or standards within their state and need to be transferred. There's also a subset of children visiting emergency departments who are children with special health care needs. As technology grows and as the practice of neonatology continues to evolve and the practice of trauma care continues to evolve, and we have such things as transplants, pediatric transplants occurring, many children will be discharged to home with special health care needs. In an ideal world, these transfers or discharge to homes will have very good, clear-cut follow-up instructions available to the medical home where these children live and also to the emergency departments in the communities in where these children live, which will dictate when these children are having specific symptoms and may need the expertise of a pediatric specialist and require transfer as well. Approximately 27% of pediatric emergencies are treated at rural community EDs. For hospitals in remote or frontier areas, this may equate to only 1 or 2 children per day being seen. And approximately 5% of all pediatric emergencies will be admitted for treatment. And this does not include children who are transferred. Next slide, please, Crystal. As of 2010, the American Hospital Association reported that approximately 5,800 hospitals existed in the United States. Approximately 25% or 1/4 of these hospitals are designated as critical access hospitals. We are proud and excited to say that many of our affiliate hospitals are in fact critical access hospitals, and we are very happy to have you join this collaborative. Critical access hospitals, for those of you who have not worked with them very often, they are actually approved by Medicare, Medicaid. They have some different financial considerations because of their vulnerability, and they are put in place to assure that medical care is available in these smaller communities. They're constrained somewhat in that they have only 25 inpatient beds. They can be no closer than 35 miles within another facility. Typically, they cannot keep patients longer than 96 hours Otherwise, those patients need to be transferred. They do have some diagnostic capabilities, and they are required to have their emergency department open 24/7, but they may be staffed somewhat differently in those emergency departments. And as I mentioned, we have many critical access hospitals participating in the affiliates. One of the states that has come on board with many critical access hospitals is Kansas, and they will be working with the MOCAN ROC team. Not all hospitals in the United States are children's hospitals. Only about 5% or 250 of them are kids' hospitals. Some states have numerous children's hospitals. Ohio has 7, Missouri has 5, but not all states have children's hospitals, such as Wyoming and North Dakota, and even Kansas, although I've heard rumor that Kansas recently has had a new children's hospital built or designated within the state or identified. 52% of hospitals admit children, and yet they may not have a designated pediatric ward or department. And part of the reason for this void, by not having a pediatric void, is that most pediatric EDs do not really end up admitting children, and therefore the smaller hospitals would not need a ward or a specific unit. The number of children treated are smaller, as we've already mentioned, and the primary work of non-children's hospital is providing care for adults, and thus the bed allocation and the budget often is focused on the primary clients or the adult. Yet interest in improving emergency care of children at community hospitals cannot be underestimated. More than 4,000 hospitals participated in the 2013 Pediatric Readiness Assessment. We were excited and ecstatic when we saw that involvement, and yet at the same standpoint, many of these hospitals have gone back, have been working on improving their readiness and retaking the PEDS readiness assessment to identify gaps and determine next steps for improvement. And as we've mentioned numerous times, we are now have almost 150 hospitals participating in this collaborative, everyone desiring to improve their capabilities of providing optimal pediatric care to kids and their families when in the ED. Another major void that we've identified that frequently requires interfacility transfer is the limited number of pediatric critical care units. Only 10% of hospitals actually have pediatric care units, and many of them are in the kids' hospitals, and we'll talk about that in just a few seconds. Crystal, can we go to the next slide, please? On this slide, what we are seeing is a map that demonstrates where the pediatric diplomats, our board-certified pediatricians, are working. And this map is put together and is monitored to see where the pediatric subspecialists go on a regular basis by the American Board of Medical Specialties. So as you can see here, there are many dark areas, and you can see that at the bottom of there, where there are no pediatricians available. Pediatric specialists are few in number in comparison to the general pediatric population, and are often described as contributing to the maldistribution, are not readily being available of specialists. Pediatric specialists are available right now in about 47 states, but there are several states who have none. Next slide, please. In this slide, what we're looking at specifically, I mentioned pediatric critical care units being very limited. PICUs, about 254 are in the kids' hospitals, and there's about another 100 that are scattered around. And in comparison to this, as we talk about other pediatric subspecialists, There are only approximately 736 pediatric radiologists in the entire country. So if you have a child who needs sophisticated radiological diagnostic tests, you're not going to find those in the bulk of hospitals today. Again, they will be found typically at the tertiary pediatric care centers. Pediatric surgeons, about the same numbers, 774 are available. And I guess the one, having worked in trauma for many years, that are very, very limited, that most folks don't realize. There are pediatric rehab specialists. They're referred to as physiatrists, and there's only 165 of them in the entire country. So in order for a child who's been severely injured to access one of these specialists, he or she will more than likely need to be transferred. Next slide, please. What we have here is the Emergency Medical Service for Children's mission. The goal of this program, it's a very small program as we introduced many of you to early on in the collaborative, is to ensure state-of-the-art emergency medical care for ill or injured children and the adolescent, to ensure that pediatric services are well integrated into the emergency medical system and that they are supported with optimal resources as possible. And then to ensure the entire spectrum of emergency services, including primary prevention of illness and injury acute care and rehabilitation, are provided to children and adolescents and their families. When we know that subspecialty care for children is so limited, we have no way of meeting this mission unless children in need are referred onward to specialty centers. Can we go on to the next slide, please? The next slide is one of the MSC Performance Measures that all grantees, all states and territories in this country who are funded by the federal EMSC program, and they get very little funding, but they were asked to work on this. And this particular measure says that they will increase the percentage of hospitals that have written interfacility transfer guidelines with the following defined essential components. Guidelines should include the process for transfer, the process for initiating transfer, including responsibilities of both the sending and receiving facilities, a plan for sending the medical record, a copy of the signed consent, process for identifying an appropriate transfer service, process for selecting an appropriate facility, and a plan for transfer of the patient belongings while making sure that directions and referring institution information is available to the family. So over the years, as performance measures were rolled out in 2009, our EMSC grantees have been working within the state trying to make sure that these guidelines are available at every hospital. And initially, we did receive some pushback from our tertiary care facilities until they suddenly realized that if a disaster were to strike, many of their patients that they would be getting would need beds that would require transfer of the lesser ill or injured children to another care facility. So having interfacility transfer processes in place are critical for every hospital, not just the smaller hospitals who need access to pediatric specialists when they arrive at their ED. Next slide, please. Achievement of this mission means that we need to assure transfer of the patient to the right resources, which may mean getting the right patient to the right care facility and the right resources at the right time, or it may actually mean bringing the right care and the resources to the patient while using such technology as telehealth. Many times, interfacility transfer, as we know, has some safety concerns as related to transport. It also has a huge impact on family. It has an impact on disruption. Mothers and fathers typically want to be with their children when they're critically ill or injured, and therefore will will follow the child to the receiving institution where care will be continued. But when they do that, they frequently have children at home who need to have follow-up and care, and they also have extreme constraints related to employment and having an opportunity to maintain their livelihoods while they are still close to their children. So transfer is never necessarily a preferred treatment modality, but it is essential for those children and preferred when they need access to a pediatric specialist or pediatric critical care unit. We also need to understand that there are associated costs as related to transfer as well as to family. I had the opportunity to work with some of our territories as they were looking at how to reduce costs, the frequency of interfacility transfer. So they implemented a telemedicine or telehealth program in many of those territories. And then they began looking at the costs, and a cost to move one child across the ocean to Hawaii, where most of them go, runs approximately $14,000 one way. So it is an extremely costly endeavor that we need to consider. So improved patient outcomes as patients will occur if these children who are in need of specialists can be directed to facilities with optimal capabilities for a specific illness or injury, or the resources need to be brought to the child. Can we go to the next slide? This particular slide is primarily showing you that this is not a new concept. We're trying to match patient needs with resources that are available. This has been going on probably the first pediatric process to match patient resources was the perinatal program. Trauma came along approximately 40 years ago, so that process is in place for the severely injured. Stroke has been more recently, STEMI has been more recently, and burn has been up and going for quite some time because I don't know how many folks are aware of it, but there's only approximately 125 burn units in this entire country, and most of them are non-pediatric, but most of them do in fact take care of burn children. So with that being said, one of our jobs when we think about interfacility transfer is, have you ever really considered where the closest burn unit is? Have you really considered where the closest trauma center is that takes care of children to help you with resuscitation? And have you thought about incorporating telehealth when necessary to help with some of those resuscitation efforts, and perhaps in some cases, such as the territories and Pittsburgh, where one of the EMSC State Partnership Regionalization of Care grants was placed several years ago, they were actually able to reduce the number of transfers by having access to the specialists who were at the tertiary care centers. Can we go on to the next slide, please? Okay, so pediatric readiness and the assessment data. What we found out in 2013, only 69.3% of responding hospitals reported having interfacility transfer guidelines available to guide care providers in planning transfer. So though that number is low and we have made it one of the intervention bundles, I will tell you when the program first started looking at interfacility transfer processes, only it was slightly over 40% of hospitals had interfacility transfer guidelines. And one of the discussions that was frequently had was when providers are already anxious over the provision of care to kids, and you throw in that child being critically ill or injured, this is not the time to try and figure out where do you send the burn child or where do you send the child for pediatric trauma care. This is the time to have pre-planned guidelines and arrangements made, and by having such, it provides some level of comfort and increases opportunities that children will be moved expeditiously for needed expertise and resources that are not necessarily available at all facilities, as we showed earlier. Next slide, Crystal. For those of you who are working on this particular bundle, I want to highlight one of the resources that you will have available to yourselves as you work on the bundle. And this particular resource is the Interfacility Transfer Toolkit. And I'm going to show you some slides in just a second, highlighting some of the sections of this. But this was a remarkable toolkit that was put together with leadership of the EMSC program and working in tangent with our Emergency Nurse Association partners, as well as members from the Society of Trauma Nurses. Both of them have standards or policies in place that support the need for interfacility transfer of patients when additional expertise or resources are needed. And as we've mentioned earlier, this is especially true for children. Next slide, please. If you look at the toolkit itself, section 1 is an introduction, but section 2 is actually an algorithm for developing transfer processes specific for kids, and it's a step-by-step way to get started developing an interfacility transfer process for your hospital. And it provides the pathway in 2 different directions. If you have an existing trauma transfer agreement, but it doesn't apply to medical patients, the algorithm can help you convert what you have to work for both groups. If you have no transfer agreements and our guidelines, the algorithm can give you the tools and information you need to go to your ED leadership and hospital administration to begin the conversation why transfer processes need to be more organized for your facility. Section 3, can we go to the next slide, Crystal, please? This one actually contains some live links that the EMSC program did some research and took some time to identify to look at rules and standards that exist in some of the states. It looks at the ENA standards of practice, the Joint Commission and CMS standards addressing organized interfacility transfer processes. It talks about the professional organizations that address the need for organized transfer processes through a variety of educational resources, such as the Trauma Nurse Core Course, the Emergency Nurse Pediatric Course, the Transfer Nurse Advanced Trauma Course, Rural and Trauma Team Development Course that the Committee on Trauma has developed, and the Advanced Trauma Life Support. Can we go to the next slide, please? Other sections in the toolkit include some talking points for establishing guidelines. There's a section on agreements and MOAs, which we're not going to get into, but you certainly can look at on your own. Section C talks about, or 6 talks about interfacility transfer guidelines specifically. Here you will see some consultation and transfer guideline links that will take you to tools that you are able to download and actually utilize. There's an authorization and consent for transfer samples there. Again, templates that you can take and convert to your own hospital's needs. And then there's also a downloadable transfer checklist that allows the staff nurse who's not used to transferring patients on a regular basis to make sure that all of the dues have been completed prior to transferring, to make sure that that child is being transferred safely and that the appropriate information is being provided to the receiving facility, as well as families are being provided the information they need so that they can join their child as quickly as possible. There's a section on cultural and family consideration. There is a section on quality improvement and follow-up. We'll spend some time talking about the need for follow-up reports for children, well, for all transferred patients, actually, and there's actually a follow-up template in there that could be utilized, and we will also be having available a template specific for you all as well for the collaborative. There's also a section on making a case for proactive transfer processes. When you go to the toolkit, you might want to look at that case study first because it's a common problem that occurs sometimes with children. A little girl who had a piece of popcorn stuck in her bronchial, and I think it makes a case for making sure that children do get transferred for specialty care when we can't identify what's going on, and I can understand how this particular situation occurred. There's also a section that has numerous library resources that you may find of help as well. Next slide, and I think I'm about done here. Kate, I'm turning it back to you. Thank you.
So I'm actually going to let Crystal speak about the AIM statement and walk you through the initial steps of the bundle, and then I'll come back and speak a little more about the quality measures.
All right, folks. So the AIM statement for the interfacility transfer bundle is that by December 2019, all those sites that are implementing this particular bundle will have a comprehensive plan that addresses the following pediatric-specific components. So there should be a defined process for the initiation of a transfer, which includes the role and responsibilities for referring and receiving centers, a process for initiating transfers, selecting the appropriate receiving center, selecting an appropriately staffed transport service, a process in place for patient transfers, and this includes obtaining informed consent and a plan for the transfer or the copy of that signed informed consent, transferring of medical records to patients' personal belongings, and then a plan for providing patients and families with information regarding the transfer process, along with details about the receiving center. And so we realize that this is a structural measure. We'll talk to you a little bit more about that in a second. But the goal is really that all of the sites that are participating in this collaborative will have some standard written series of documents, perhaps, that outlines these core components of interfacility transfers. Here you'll see a snapshot or the beginning of a key driver diagram, and it's really just a display that's commonly used to outline some strategies for improvement rather than sites just serendipitously starting intervention strategies. We are going to ask that they sort of adopt some of the change strategies that we're proposing from the subject matter experts. And so some of the categories of interventions will relate to these 5 components. That first piece is really about the policy and procedures that your hospital has in place for interfacility transfers. The next piece is how are you going to educate the care team about those procedures that you've established. There needs to be some piece about communication and follow-up. As Kate mentioned at the beginning of the session, the sort of cornerstone of the interfacility bundle is patient-family engagement. And so we have a series of change strategies that you should consider to engage families. And then lastly, we know that nearly 98% of the hospitals participating in the collaborative have an electronic medical record, and we are going to provide just some options or ideas for how you can optimize the use of your EMR platform. So what we'll do is go ahead and start with the first category, which is the written procedures guidelines for interfacility transfers. And so some of the change strategies that we're asking you to adopt is that you may want to begin by assessing the availability of your hospital's pediatric-specific resources and really try to understand what gaps exist at your center and your ability to provide comprehensive pediatric care. The next step in that could be compiling a list of common pediatric diagnoses or cases that routinely warrant a transfer at your center. And then really the integral piece to this change strategy is that we're asking that you convene a group of ED leadership, any relevant stakeholders to establish a minimum criteria for pediatric cases that should be transferred to another facility. And then lastly, develop an interfacility transfer plan to address those targeted components that I mentioned earlier. We have listed 2 change strategies that will be required by all sites participating in this bundle. The first one is the development of a checklist to assist the care team during an actual pediatric transfer. We know that sites definitely have routines in place, but we think it may be important for you to revisit that process. And so we're hoping that what you'll do is use some of the resources that are available within that toolkit and some additional resources that we'll be providing to really develop a comprehensive list of all the action items that need to occur to ensure that you have an appropriately timely, patient-centered, and efficient transfer to another facility. The other piece that will be required for all sites is that you should be providing an informational packet to family members for all children that are being transferred. That packet should include a copy of the signed transfer consent, including the reason for the transfer, the name, address, phone number, directions to the receiving center, and include specifics of where the family is to report, and also information about the name of the physician that's referring and accepting and their positions at the facility. And so what we'll do is provide you with some templates to help you with this process, but these are the required tasks for this particular bundle. The next piece is education. So what we are encouraging sites to do is consider developing some education plan, or maybe it's a series of brown bag sessions or workshops to educate the care team on interfacility transfers. And some things that you may want to consider is just covering what's the transfer criteria for your hospital, and really stressing the importance of the need of pediatric transfers at your site. It may be that you are discussing preferred receiving centers and the importance of family input. You may decide to bring a member of the administrative team in to really help you understand how insurance may aid choices where they decide to go for their subsequent care. The next piece of education could be related to patient transport modes and strategies for selecting the appropriate method for transfer. So our goal is really to find ways to ensure that the team has the most comprehensive information that will help them make the best choices available. And then lastly, review those transfer guidelines, the checklists, and family packets. The next piece that we are also encouraging sites to consider for education is to consider virtual webinars or periodic conference calls with their referring and receiving centers, just to keep them updated on the transfer process. Let's say that the hospital has moved their emergency department to another area of the hospital, or there are new members of the care team that are involved in the transfer. It's important that we keep that communication going, and so we would hope that sites are doing some education to keep both parties apprised of changes and updates. The last piece is that you could consider integrating tabletop exercises, really just to reinforce the facility transfer stages. The next section for this bundle relates to communication and follow-up. So we are asking that sites really take some time to establish a feedback loop between the referring and receiving center, and that would include working with the nurse manager at the other emergency department. It could be working with the local QI coordinator or educators at both locations, but really to start discussing how we can make improvements in those transfers, opportunities for improvement, and some of the best practices that you may want to use for other initiatives. We will provide as a collaborative a transfer follow-up form that should help you with your existing transfer process. And so what would happen is that the receiving center would send feedback to the referring center about the progress of that transfer. And so some of the specific information could be some of the services that were rendered at the receiving site. It could be practices or actions that impacted the transfer in a positive manner. It's always good to have positive reinforcement. And it really fosters a relationship and a collaboration between the referring and receiving sites. We are going to include a section in that transfer follow-up form that includes potential areas of improvement. And so we're hoping that sites really take time to consider what hospitals are they commonly referring patients to, and work with them, make it a collaborative. A lot of you guys are working as a network. This is a great opportunity to start this communication or 360 follow-up regarding care. The other piece is that during staff meetings, we are going to encourage you to really highlight lessons that you've learned, particularly from that transfer follow-up form, and then consider including all patient transfers as sentinel events that are discussed at your local QI meetings if you are hosting those sessions. As we mentioned earlier, patient-family engagement is a cornerstone of this bundle, and so some of the change strategies or improvement work that you can do may be developing a checklist for families that outlines the transfer process and includes considerations based on the patient or family's personal preferences. There are a couple of examples out there, and so we'll get those posted on the website as soon as we can. We are asking that you create these family transfer and informational packets in advance. So we would hate to see the care team pulling forms or printing them from different areas, but that you really are thoughtful about the content that goes in that packet, that it's created in advance, and that you're avoiding the use of generic content. The other option is to work with your state's EMSC family representative to assist in the development and validation of the content that would be in that packet. Each team has an EMSC manager associated with the training site, and so we can definitely help connect your hospital with the EMSC manager who can help you find that family representative. The other piece is that we're asking that you integrate a feedback program whereby families will share their experiences with the transfer process. So it's just not the care team saying, hey, I sent you a receiving form or feedback form on how we believe the process was, but we want to hear what's happening with the families. And so this is an optional piece to this bundle, but we strongly encourage sites to consider really getting feedback from your families on the transfer process. The next piece is EMR optimization. As I mentioned earlier, several of our sites have electronic medical records, and so we sort of came up with a list of something that you may want to consider. So consider telehealth consultation for the assessment of need and care or for resuscitation interventions prior to transfers. It could be that you include fields like decision time for transfer or time receiving center is notified, just to help you with the timeliness of your transfers. And Kate's going to talk a little bit more about that when we get to quality measures. The other piece is that several of our sites have patient portals. For instance, Epic has MyChart, and what you may consider is, rather than giving a family paper packets to go to their receiving site, you may import all that information into their patient portal that can easily be accessed from their app or through their laptops. And then the last piece is that we want you to inquire about the patient satisfaction surveys that your hospital uses. It could be Press Ganey or another vendor, but this may be a way that you can assess the transfer process from the patient's perspective. And so now Kate's going to walk you through our quality measures for this intervention bundle.
Great. Thank you, Crystal. So just, as further emphasis and as a reminder that all of these change strategies are really just suggestions. We're going to be providing you all additional resources to help implement them. Much of the information that Crystal just reviewed are items that can be discussed during those team meetings for discussion with your trainers and also with other affiliate sites or other pediatric champions at other affiliate sites within your team. so that you all can learn from each other about what may or may not be working well. I will say that while EMR optimization can be very useful and highly successful in improvements, it can be a little bit more challenging to implement. So think of that as something that may require a little bit more time to actually make that change happen. The other pieces regarding all of this, one of the things I touched on with culture is that this is really grassroots. So everything that you're implementing is locally defined. We're helping to create some frameworks, we're helping to create resources, but we are not dictating what standards or what criteria should be followed. That is entirely based on the resources that exist at your institution, and you all as the champions and or trainers know that better than anyone. The last thing is that some of you may have different aspects of this bundle already in place, and so you may already have a transfer plan, a local interfacility transfer plan that encompasses all of the pediatric specific components. Others of you may not. So in terms of progress made through this bundle is also going to be dependent on the type of support you have and how effectively you're able to achieve these changes. And that's not based on you, but based on the amount of support that you have within your facility at being able to implement these. So hopefully that's clear. What we're going to talk about next are the quality measures and some of the data. And the purpose of this is really to allow you to measure your own progress so that you have talking points back to your internal local institution, to the ED leadership, to hospital administrators about the impact of the work that you're doing, and also to be able to provide some benchmarking, because you'll be able to see aggregate data from all sites that are participating so that you can see how the work you're doing is potentially comparing to all the other sites or to similar sites to yours based on the type of institution that you're representing. So in terms of quality measures, as Crystal mentioned, and we'll be mentioning further on, is that we are using the IHI, the Institute for Healthcare Improvement model for quality improvement collaboratives. And as we talk about quality improvement science, we talk about structural measures, process measures, and outcome measures. And if you haven't had formal education on quality improvement science, you'll be receiving more of that through the IHI modules. But within each of the bundles, we've tried to identify structural process as well as outcome measures to really identify improvement. So structural measures are, of course, pieces like having a process in place, having a plan in place. And the first, of course, is a plan that encompasses the 8 pediatric specific components, and then also establishing minimum criteria that works for your facility for patients who should be transferred. Again, that's locally dictated, not dictated by the collaborative. We then start looking at process measures. So this gets into timeliness and percentage of transfers, et cetera. And so a first process measure is the timeliness of transfer, median time from arrival to transport. There is not a set goal here, but it gives you a way of looking at how timely are we, how well are we doing related to those transfers, and being able to compare them against a national group. The second is the percentage of transfers that met site-specific minimum criteria, and that's based on your site-specific criteria. And then the third is the percentage of families who received the transfer informational packet that you'll be creating that gives them directions and belongings and things of that sort. And then lastly, we have 2 potential outcome measures. And the reason that these are optional is that they require feedback from the receiving centers. And some of you may have easy relationships with receiving centers and may be able to obtain this data right now. Others may have to work with the receiving center to develop a process to obtain this data. And in another group of you, it may just not be feasible. But we encourage you all to consider working with your receiving centers so that you can get at these 2 outcome measures. The first is, of those patients that are transferred, what percentage were discharged from the receiving center's emergency department, meaning they were never admitted. And this really gives us a sense of some potentially avoidable transfers. It doesn't mean they were truly avoidable. It just means they're potentially avoidable, and allow you to look at who that population was to identify opportunities. And then the second outcome measure, the percentage of patients that were admitted and discharged from the receiving center's inpatient units within 24 hours of arrival. So again, potentially avoidable transfers. They may not be fully avoidable, but at least worth looking at that population to see if there's specific needs that could be addressed at your institution. So in terms of variables, within each bundle, there are, of course, the site-specific variables, and these are really related to some of those structural components. So does your site have an interfacility transfer guideline? Does it include all of those pediatric-specific components? Does it have minimum criteria specified for pediatric transfers? It may not be all-inclusive, but this is just at least minimum criteria. And then finally, does the site have telehealth capabilities that may be utilized for transfers? Go to the next slide. This is when we start looking at the patient-specific information, and remember that all information entered is de-identified data, and this allows us to help track for you all metrics related to your performance and allow for benchmarking. But this would be, so the date and time of the patient's arrival. As we receive feedback from trainers at the in-person meeting in Austin back in January, we went through a number of these specific times. And some of the recommendations were that we might not be able to get at all of these times. But if they do exist, the time of arrival, the triage time, the time that transfer services were confirmed, and the time that the patient actually departed your site or the referring center. The next is, how was that patient initially triaged? Did they meet specific criteria for transfer based on those guidelines that exist within your institution? What was the reason for their transfer, and or were there any delays? Was telehealth used, and how were they transferred? Meaning BLS, ALS, pediatric transport service, and the like. If you're able to work with the receiving centers, these would be the questions that you would want to get feedback on. First off, was there a final diagnosis given for that patient? And so here we're talking about ICD-10 codes that the site would be able to provide, and or an ED diagnosis. Any procedures that might have been conducted at that site. And really, we're not necessarily speaking about specific procedures, but was diagnostic imaging done? Were diagnostic procedures done? Were surgical procedures done? And was sedation done? Because this gets at the potential need for those transfers. And then lastly, when that patient was dispositioned, either discharged or admitted. So at what time did that occur? And then the last piece of this bundle is about the family-centered care piece. And so for any patient that might be transferred out, ideally those families should receive a transfer packet. And so this is really to be done at your site to get feedback from the families that you're serving, which is, did they receive the transfer packet? Did they feel comfortable with the reason for the transfer? So did they feel like they understood it? Were they satisfied with the details provided about where they were going? And then lastly, what was their overall score or satisfaction with the transfer process? Now, these are suggested details that would be part of that. Of course, you may modify a family evaluation form to include more details as you see fit. But these are some suggested minor elements or core elements if you choose to implement a family evaluation form for the transfers. You'll see the whole expanded list of variables that will be part of the intervention bundle. Those are on pages 7 and 8 of the bundle, and you can review those in full. And you'll be receiving that. And then the last piece is just, again, with the data collection. So again, everyone who submitted an application for this collaborative had their hospital administrators and ED leadership sign letters of commitment that spoke to the use of data use agreements. If you're struggling with getting those in place, we recommend that you reach back out to those leaders who signed those letters of commitment. Unfortunately, we can't help you with any of the metrics or analysis unless you're able to actually enter data into the database for this collaborative. And as I mentioned, nothing that you enter in there will be shared with other sites directly. Only aggregate data will be shared. We will not be sharing your performance for data with any other single site, whether that be a training site or affiliate site. It's up to you to decide whether or not you want to do that. We certainly expect that those sites that are part of a network will be very transparent about their performance. Other sites may choose to share only certain pieces of their data. But we do encourage you to be as transparent so that others can help support you as you address some of the barriers and challenges. We will be developing specifically a how-to guide for the data submission. We'll be releasing that towards the end of this summer. That will provide you with specific information on how to enter data and what the specific issues are related to confidentiality and privacy and the like, and also how that reporting will look. As I mentioned, each site will have ownership of their own data. We will not be sharing that directly with any other sites. But the real benefit here is that every single site will have their own dashboard, essentially a reporting dashboard where you'll be able to see, based on the data that you've entered, how you're doing as you move through various Plan, Do, Study, Act, or PDSA cycles. And you'll learn more about that with the QI education. For intervention-specific bundles, there will be reporting in aggregate for benchmarking purposes that you'll be able to look at. And then, of course, there's also going to be a comprehensive dashboard for all sites to see general progress overall that is related to the work that's being done. So at this point, I'll turn it back over to Crystal to talk about some of the resources that are available.
Thanks, Kate. So if everyone's not familiar with our file sharing site, you'll see the link that's listed here. On our file sharing site, we have the intervention bundles that are available, the foundational articles, the DUA content or data use agreement content that's been emailed to all the sites. All of our learning sessions have been archived, so you can find a copy of the recorded session as well as the slide deck. And then you'll also see the calendar of events for 2018 and 2019. Now, within the intervention bundle section, you'll see that we have folders for each bundle that we've discussed thus far. So you have disaster planning, which was our first bundle that was released. We have abnormal vital signs, and then today's bundle is currently posted for interfacility transfers. Currently within this folder for IFT, you will have the bundle as well as a copy of that toolkit that Diana mentioned that's quite comprehensive, that has embedded links there. And so we're encouraging you that as you're reading through that toolkit to go ahead and download those documents that are embedded. This will provide a lot of those extra resources we've discussed. And we'll constantly be adding new content to this section. Now, the other piece is that we realize that some hospitals have firewalls that are preventing them from viewing content that's on box. So I'd encourage you to let us know, send an email to QECA at texaschildren's.org to let us know if you are having trouble with your firewall. And what we'll do is just send you several emails with this content to ensure that you'll be able to access the resources. Housekeeping. So administrative-wise, we really need you to establish your data use agreements. You're going to be receiving messaging from Eduardo Zamora from University of Utah and NEDARC, as well as Terry Fisher from EMSC Innovation Improvement Center. That's going to be the first step. That is really the entry point to ensure that sites get access to that IHI modules, and that we'll start sending you information related to the data portal. If you haven't done so already, you should have completed your first site visit with your training site. If that has not occurred, we encourage you to let us know in the comments or the questions section so that we can reach out to the training site and let us know if any barriers exist. And don't forget to complete that Site Visit 1 survey. As Kate mentioned earlier, July 1st was the first sort of major milestone that we were requesting that all sites had completed that their data use agreements, but there's still time, and so we're encouraging you to go ahead and work with your hospital administrators, your C-suite to get those agreements established. And then based on that, what we'll do is release the login information for 2 users per site for the IHI modules. And then we will have another opportunity for you to send us contact information for those individuals that will be responsible for submitting data for your site. And remember, September 1 is still our target for when we're hoping that sites will be ready to start collecting baseline data and really working with their teams to develop an implementation plan. So this is where we are, you guys. Weighting kilos is the last bundle that we will discuss on July 17th. We will release that bundle this Friday. We know we've been tardy, but we are looking forward to getting this last bundle out to the masses. And then disaster planning, there will be a part 2. So I'm literally waiting until this call is over so that I can press send on the invite to send that out to all the sites. And this disaster planning part 2, we realized that the disaster bundle is quite unique compared to all the other bundles, and that it will require some time for us to really work through the processes, workflows associated with those 4 domains that we've discussed. And so what we're going to do is spend some time on July 31st walking sites through that bundle. So if your hospital is interested in doing the disaster bundle, I would encourage you to get members of the care team on that call. We will have time for question and answers, and there will be materials that are distributed prior to that session. And lastly, what I'll do is just remind you guys that we are providing CNE and CME credit. The key term for today is Transfer Deep Dive. And you'll see the link listed here as well as in the chat box. Now I'd like to pass it back to Kate and see if we have any questions. So one question just came in. When will the environmental scan for these bundles be released and due? So what we've decided to do is staged approach. Initially, our team had thought that we'd go ahead and send out all these surveys to sites to get their feedback. But what we're realizing is that it's probably more thoughtful for sites to go ahead and establish their data use agreements, have time to work with their ED leadership and their hospital administrators to select the appropriate bundle that they're going to choose. Then they'll have access to the data portal, and then they'll have access to the environmental scan. So rather than sending the information out haphazardly and sites still haven't received buy-in from their hospital, we want to do it in a stage approach. So as soon as your hospital gets their data use agreement established, we'll start sending them communications specifically related to those next steps. Kate, Diana, any final comments while I check?
Just thanks to everyone for joining today. And if you do have questions, of course, please submit them into the chat box. We'll stay on for the next few minutes just to see if any questions pop up. And we're happy to try to answer those as best as possible. You're also welcome to join us, of course, for upcoming office hours and the like. We do have DUA specific office hours that are scheduled next week following the intervention bundle. So if you have any questions or issues regarding that, please consider joining.
Any other questions, you guys? Okay, Kate, we have one that just came in. Just to be clear, who is the most desirable individual on the care team to hear from the feedback loop regarding the interfacility transfer process? So which members of the care team should be receiving feedback regarding the effectiveness and efficiency of the patient transfers?
So I think that's going to have to be site defined on how you determine that process. In some institutions, it's one of the ED nurse managers or nursing director who receives that information. If you're specifically signed as the pediatric champion, it may be, delegated specifically to you as the champion, in which case you can set up a process where you would receive those transfers directly. Hopefully that answers the question.
And so the link for the previous sessions to get your CME credit is actually the same link that's listed here. There aren't any changes. And so what you would just mention is the name of the bundle. So for our last session, it was Abnormal Vitals. Just list that as the event or the session that you attended. The one prior to that was Disaster Planning. So just use the link that's listed here and you'll be able to access information for those previous sessions. Okay, Kate, if this bundle, okay, so we have a question from one of our sites that's asking if this site isn't the bundle that that their hospital has formally chosen, but they want to improve their transfer process, can they use ideas from this bundle to improve the transfer of their kids and families? So the question is really, although they are not formally working on this bundle, what are your thoughts about still adopting some of these principles into practice, but not submitting data for it?
Yeah, so absolutely, as part of the collaborative, you have access to all 4 of these bundles. So you are welcome to use those locally. The one thing that I would say is that you are not restricted to working on just one bundle. We certainly would like folks to begin with just one bundle, but if you are really going to work on any of these interventions, I would really encourage you to consider just adding on a second bundle. You may do that, sequentially, or you may do those even simultaneously, where you're working on one bundle at a time, or I'm sorry, more than one bundle at a given time. So that's certainly possible. We just would like folks to choose one, at least to start with up front until you get the hang of the process. And then, feel free to dive into other bundles as well.
We have one of our subject matter experts that did join the call today. Her name is Sally Snow. And Sally, I am going to look for you in the list of attendees, and I'm going to unmute you so that you can sort of share some of your insight. Can you hear us?
Yes, I can. Thanks. Just wanted to reach out to you guys and let you know that there are 3 very good subject matter experts on this bundle, and we're all willing to help in any way we can. I'm sure our contact information will be shared within the bundle or in the collaborative, so please don't hesitate to reach out. This is a process that many of you may have in place already and just need some advice on how to refine it. And some of you may not have a transfer process in place at all and just need to start from ground zero. But all of the subject matter experts, Tony, Lisa, and I, are here to help and are willing to do that anytime you need us. So please don't hesitate to reach out.
Thanks so much, Sally.
We just got a question about the disaster deep dive. So literally after this call ends, I'm going to press send on my Outlook calendar, so you will receive that invite. So literally it's going to be about us just ending the webinar and you'll receive it. And yes, I would encourage you all to share that with your disaster preparedness teams at your hospitals. We will have the subject matter experts will actually be presenting this content. So you won't hear your usual moderators, Kate, Diana, and myself, but it'll really be those individuals that have a proven track record of disaster planning within their designated domains. So that's going to be coming soon, like literally as soon as we hang up, Carrie. Anyone else? So we've got about 8 more minutes. I just want to remind everyone that the slides for today will be available on the file sharing site. If you are having trouble accessing any of the links that's listed here, just open up the actual slide deck, click on that link, and it will take you to any of the surveys that are listed. Any other questions? So our next question, are arrangements already made for applying for MSC credit, or will that be rolled out at a later date? So we are planning on starting the MSC component of the collaborative in September, because that's really the time that we're going to do the implementation work. And so we have a learning session scheduled for August 28th with all of our sites. During that time, what we'll do is outline the process for obtaining MSC credit. Remember, that's not just for the pediatric champions, but that's anyone that's on the care team at your hospital that's boarded through the American Board of Medical Specialties. So we will start that process in September when we go live. It will be geared to those physicians that have sites with DUAs that are established. But we will definitely be rolling that out. And our goal for participation will be that physicians must participate for 9 months to receive, if they're boarded through, let's say, American Board of Pediatrics, the first 9 months would award them 25 points towards Part 4, their MOC transcript, and then another 9 months of participation would get them the subsequent points. So what we'll do is we'll get that sent out to you guys during the August 28th learning session. So it's on its way, Christopher. The other question that we had is, I have 2 different bundles, this one and abnormal vital signs. Is there anything I need to be doing right now? Kate, Diana?
So regarding this vital sign, so as Crystal mentioned before, I think the biggest issue is getting the DUAs established. The second piece would then be looking at or considering potential change strategies, and you should be meeting within your team to talk about that aspect. I think that if you already know this is a bundle that you plan to work on, then it would be maybe beginning to have some of those meetings with your ED or hospital administration leadership, more likely the ED leadership, just to try to determine what might be feasible. And I think the last piece would be really making sure you understand the current process in place. So those are all part of the first steps of knowing the process, trying to identify or obtain buy-in, identifying potential change strategies, and then you'll begin to do that work. But we don't expect people to be doing a ton of that work up front until you know for certain that this is one of the first bundles that you plan to adopt. And then again, as Crystal mentioned, once we have those DUAs in place, we'll be sending out the environmental scans, access to the IHI modules, and the like, so that you're readied before the start of the implementation.
Hey, Kate, and I'm going to piggyback on that. That came from Elizabeth. Another thing that you may want to consider is that we don't want you as a pediatric champion to do this alone. So this may be the time that you reach out to some of your colleagues in the emergency department. It could be an existing quality improvement specialist that helps out. It could be just a physician or nurse that's engaged in providing better pediatric care. I'd encourage you to refer them to our file sharing site to get some basic content about the collaborative. And really, this is the time that you build your partnerships with your team, because you won't be able to do this alone. We don't expect for you to do this alone, but it's a great time to get some support from your colleagues. Any other questions? We have about 4 minutes remaining, you all.
I'm going to echo, Crystal, what you just said for Elizabeth. I think at this time and point, Kate's correct. You've got to get your DUAs done. We also need to get you the IHI information after that, so that you guys can participate in those modules, and establishing
a team to help you is probably going to be one of the most critical pieces to ensure that you're successful in your own individual affiliate sites. A team who buys into the need of interfacility transfer, our abnormal vital signs, getting that process organized, and a team who can actually provide support to you and support to others as you're moving forward with the individual intervention bundles.
Thanks, Diana. So I think with that being said, we are going to give you back 2 minutes of your day. We will see you all next week for the next bundle, which will be weight in kilograms. Thanks everyone for joining, and have a good day.
Thank you all.